How much elbow forearm motion do you really need? Everyone says all of it, but I'm not making any promises. I'm not going to start this video with crazy lies. Anyone who says they can fix everybody all the time is full of baloney. We have to do the best we can with what we've got. That's why I made this video. We need to stack everything we can towards having the patient recover their function. But wait, you say, there are already tons of elbow videos on YouTube. Yes, I know. But this one is my favorite. It's so good, and I've borrowed and updated their beautiful graphic. But their video is good for patients. My video here is for physiotherapists. But of course, everyone is welcome. So instead of throwing exercises at you, whoever you are, I'm putting elbow loss of motion in the physio context. I want to define the stiff elbow. This isn't just feeling resistance to motion. That's a type of stiffness too, but that stiffness usually gets better with some gentle motion. I'm talking about loss of motion, a contracture. So you start by measuring your patient's active range of motion. There's a normal range, there's my zone of concern, and then there's terrible range of motion. Everyone treats the terrible range of motion, it's obvious. Usually I treat the zone of concern, but that's where you consider the patient's functional loss when you make your treatment plan. For extension, I want to go full out to 0 degrees, but -5 or -10 degrees is probably not that big of a deal. More than -15 degrees is my zone of concern. Check the other side, because some old people are walking around all flexed up and they're like -10 degrees on both sides. Then I'd ask, what are they doing in physio for that? For flexion, 120, 130, 140 degrees is good, or when the forearm hits the biceps, then they're done. So I really like to get my patients to 100 degrees, 120 degrees to be functional. Worse than that is my zone of concern. For pronation and supination, normal is 80 or 90 degrees. 60 to 70 degrees is my 60 or 70 degrees is my zone of concern, where I'd probably still fight for some more motion, but it really depends on the patient and the situation. So my picture is trying to show that the red zone is terrible. Congratulations, your patient has a stiff elbow. If you're in the yellow zone, it's the zone of concern, then you're on the edge. Probably still get treatment, but it depends on that patient's individual situation. The green zone is normal. But normal is just a setting on the washing machine. So check the patient's unaffected side and check for functional loss. I'm laying all this out there for you because the existing elbow classifications are complicated or not clinically helpful for physiotherapists. That's the ISAKOS classification or the STIF classification. That's hilarious, what a name, eh? Instead, I've developed a more practical approach that cuts through the baloney. My 3 simplified diagnostic categories are overuse injuries like tennis elbow, traumatic injuries like a rotator cuff tear, and systemic injuries like osteoarthritis. These 3 simplified diagnostic categories affect how you approach the patient and what you expect for your outcome. Similarly, there are 3 simplified treatment stages that I use. First, pain management, then recovery of motion, and finally, strength, balance, and mobility. I did an entire video describing my approach. There's a link in the description to that video. In this video here, that's what we need to talk about for the stiff elbow: pain management, recovery of motion, strength, and function. Plus, there's a bonus. There are special considerations around the elbow, so stay around for that. Section 1, pain management for the stiff elbow, easing pain without making it worse. Patient education. Teach your patients how to manage pain with rest, ice, elevation, and compression as needed. Use in-clinic treatments like laser therapy for inflammation. Pain-free home exercises. Start with gentle exercises above and below the injury. These can help ease arm stiffness without causing more pain. For example, neck rotations. For the shoulder, cradled or supported Codman's pendulum swings. For the hand, grip squeezes. Activity modification. Encourage your patients to use their hand and arm as much as possible without aggravating their condition. Regular walking and using the unaffected arm can help keep their life relatively normal while avoiding further irritation. Section 2. Restore range of motion for the stiff elbow, getting movement without irritation. Use the arm. Advise patients to use their arm as tolerated. Remember, we just talked about this. Applying heat to loosen that stiffness. If pain returns, switch back to pain management techniques for a short time. Pain-free home exercises address the loss of motion, progress from active assisted range of motion to active range of motion to resisted motion to bodyweight exercises. For example, here to start some exercises, there's more in my book, but I would start with something like grip squeezes, table slides, pendulum swings, self-assisted range of motion of the elbow and forearm. Pain-free manual therapy. This must not be painful. Use heat, then pain-free manual therapy. I have some tips. I like to sit beside the patient, get a comfortable grip. One hand goes on the distal forearm, not the hand, so you don't stress the wrist joint. And then the other hand cups the olecranon. This is a great place to start for elbow, forearm, passive range of motion. Start with some gentle traction. The action is to pull the forearm down and separate the elbow joint ever so slightly. This is a comforting exercise for the patient. This also does some traction at the shoulder. There are other techniques. There's other ways to do traction. There's always other ways to do everything, but this is my favorite. It's so simple. For flexion and extension, you hold the forearm, you cup the elbow like we talked about, and just go up and down. Going into full extension is like the standing arm bar in mixed martial arts. For pronation and supination, use the lumbrical grip on the distal forearm, just proximal to the wrist. Remember, don't twist the hand or torque the wrist joint. Leave the wrist out of this. To be more aggressive, you can add elbow traction while doing elbow passive range of motion. There are some belt techniques from Mulligan. Consider using a towel for elbow flexion. This is a joint separation technique. This is like an elbow lock from mixed martial arts. Add Mulligan-style mobilizations with movement to pronation and supination. This is a picture of a mobilization with movement into supination. The other resource here would be the Mulligan concept book. I have the old cheap little book. It's great. I know there are newer Mulligan concept books on the Amazon bookstore, so let me know if you've tried any of those. I haven't seen any. Dynamic splinting. These are possible. I have mixed feelings because I've seen mixed results. The results with the dynamic splint seems to depend on how much tension is actually used. This can be too little or this can be too much. And then the other problem is patient compliance. This has to be the magical time under tension to get a good result. Section 3. Strengthening and restoring function for the stiff elbow. Rebuilding the whole arm function. Strengthening exercises. Focus on pain-free exercises for the whole arm, multi-joint exercises, including closed kinetic chain exercises. For example, wall push-ups, four-way TheraBand, which also does an isometric gripping exercise, the bicep curl to overhead press. Functional training. Tailor exercises to what your patient needs to do daily. For example, an elderly patient who needs to go grocery shopping needs reaching for items off the top and bottom shelves. A mother with a small child needs to be able to lift and carry, so you can use a med ball as a child simulation. Delivery driver who needs to lift boxes, you can do some crate lifting. Start with an empty crate, then progress to different heights and progress to increasing the weight load as tolerated. Hey, look at you, making it this far. You're awesome. The bonus section. There's special considerations for the elbow. Number 1, manipulation under anesthesia. This is the MUA. This treatment is not just for elbows, but it is a treatment that you may see at the elbow. Manipulation under anesthesia is a possible physician treatment for a stiff elbow. I have not seen many of these procedures done for the elbow. The major complication with any of these manipulation under anesthesias is an iatrogenic fracture. And in the last 30 years of physio, I can only remember one of my patients having a fracture complication after being manipped. So it's a pretty rare complication. Number 2, nerve injuries. Nerve injuries aren't just about the elbow. They can affect the whole arm and beyond. That's why I always stress the importance of pain-free exercises and gentle manual therapy. Gentle nerve gliding exercises are important, and everyone does those a little differently. So choose what works for you. Nerve flossing or nerve gliding, whatever. Encouraging activity as tolerated means getting patients to use their hand and arm as much as they can handle. Remember earlier I was pushing pain-free exercises for the whole arm. Multi-joint exercises, including closed kinetic chain exercises. This helps their brain adapt to the sensory input and reconnect that injured arm back into their sensory body integration. This is also called sensory motor integration, or neuromuscular re-education, or perceptual motor training, or sensory integration, whatever. Just use it or lose it. Number 3, Myositis ossificans. This is also called heterotopic ossification. This is a rare condition where bone forms in the muscles and tissues. We usually see this in young active people after trauma, but there are some neurological patients who get this. It's usually 3 stages. There's an early inflammatory stage, there's a calcified tissue stage, and there's a final bone-formed stage. Symptoms include pain, tenderness, reduced range of motion. Diagnosis comes from a combination of the patient history as being a young active person after trauma complaining about limited range of motion and pain. There's a physical exam that shows tenderness and maybe a mass in like the brachialis muscle or the quadriceps muscle or the hip adductor muscles. Imaging shows a calcified mass or ectopic bone. The differential diagnosis here is cancer. Usually the medical treatment is to leave it alone and send them to therapy. Surgery is unusual. I've seen a couple of these stiff elbows in physio over the last few years. That's why focusing on pain-free exercises and pain-free manual therapy is so important. Start with icing to manage pain. Heat can be controversial. If you're considering using heat, check with the referring physician. But if your patient is in that mature bony stage, then heat is probably okay. Number 4. Cauliflower elbow. You've probably heard of cauliflower ear in boxers. Well, some mixed martial arts fighters and other combat athletes get a degenerative elbow condition called cauliflower elbow. This isn't an established medical term, so you see this as a Google search, but not in Google Scholar. This is a rare condition, but it's something to keep in the back of your mind. The main issue here is stiffness, pain that gets worse over time with repeated trauma. There can be catching and locking. The x-rays look like the elbow has osteoarthritis in a young person. So that's my treatment path. Focus on managing the pain and improving motion without making things worse. Prioritize strength and function with exercises and home activities that your patients can actually handle. Keep things moving while managing the pain is crucial for recovery and managing function. And 2 more things. If the ortho doc isn't expecting full range of motion, usually they tell patients, usually they're very plain about that. Well, usually, sometimes they don't. Second, the principles and techniques that we've outlined here aren't just for adults. They can be effectively used with patients as young as 4 years of age. This video is an example of how my 3 diagnosis and 3 treatment category approach is a practical way for you to approach your physio patients. Your myositis ossifican patients might really have a tumor. Your young fighter might be complaining about elbow pain, might have early osteoarthritis. The medical diagnosis isn't always clear. Doctors don't always tell us everything. No, it's true that they don't. This happens all the time. Doctors get busy. As the physio, we need to help our patients without making things worse. That's why I made this video. We need to help our patients with limited elbow motion recover their function. That's why we're here. Have you ever heard of this cauliflower elbow? Have you ever seen a myositis ossificans? Let me know what you think. My 2 books are now available at Amazon. What They Don't Teach You About Documentation in Physiotherapy School, a short how-to manual for successful daily note templates, and From Injury to Recovery Through Exercise, simple functional exercise progressions for physiotherapists to restore lifting, standing, walking. Thank you for your support. Another video for you to chew on right here, and by subscribing, you'll be part of a vibrant community that celebrates everything physio. Thank you.